Hello everyone, this is Alena Isaac moderating today's session. Today we have an interesting topic to learn and discuss, outpatient parenteral antimicrobial therapy. To enlighten us today, we have Dr. Swati S. Sampan. She is a clinical pharmacist at Amrita Institute of Medical Science, Kochi. She is also a project coordinator for Integrated AMSP project at Amrita. Her areas of interest are antimicrobial stewardship and anti-TB stewardship. So without a delay, let me welcome Dr. Swati. Over to you, Dr. Swati.
Thank you for your kind introduction, Dr. Alina. So let's move on with today's topic, outpatient parenteral antimicrobial therapy. Disclosure information. I do not have any relevant financial relationships with any commercial interest. So let's look into the learning objectives of the day. We'll start with definition and the types of outpatient antimicrobial therapy, general principles guiding to OPAT, the best practices and opportunities of OPAT management. What are the safe and effective approaches to OPAT? What are the future directions and the research needs in OPAT? So OPAT is like breaking the patients free from the hospital walls, revolutionizing the treatment of infections in stable patients at home. So let's move on with the introduction. So OPAT is defined as it's the administration of intravenous antimicrobials outside of an acute care hospital setting for at least 2 doses without intervening hospitalization. So this is the definition of OPAT. So let's see what's the primary goal. It allows patients to complete the treatment safely and efficaciously in the comforts of their home or another outpatient site. So it is actually the completing the treatment safely and effectively in the comforts of a patient's home. So moving on with the secondary goals, it's reducing the inconvenience for the patient, plus avoiding the potential exposure to nosocomial pathogens and decreasing the expenses of staying in hospital just to complete a prescribed intravenous antimicrobial course. So let's have a look into what are the benefits and what are the risks of opiate. So definitely in benefits, it reduces the length of hospital stay. It limits the exposure to any kind of nosocomial pathogens. It reduces healthcare related costs to the patients. It optimizes resource allocation, like it reduces the bed spaces and the time of the nurses, etc. So what are the risks associated with opiate? So there can be catheter related complication. There are chances of adverse drug events. There is a reduced frequency of clinical oversight is not there. There is a risk posed by untrained caregivers. So this can be the risk associated with opiate settings. So let's move on with the types of opiate care delivery. So basically there are 3 different types of opiate care delivery. So the first one is the home-based mode of opiate. Second is the infusion center-based, and the third one is the skilled nursing facility-based. So we'll look into each of this with the help of case scenarios for better understanding. So we have a case scenario here where we have a 68-year-old male patient with known case of type 2 diabetes mellitus, hypertension, and this patient was recently diagnosed with osteomyelitis of the left foot. So now the patient is presented to the ER with 2 weeks history of worsening pain and swelling in the left foot. So when we looked in the labs, the HbA1c was 13 and the creatinine was 1.3. So the MRI confirmed the presence of osteomyelitis. So the patient is diagnosed of osteomyelitis. So then the blood cultures were sent and it came out positive to be Staphylococcus aureus, which was a methicillin-resistant MRSA. So given the severity of the infection, the patient was started on injection vancomycin in the hospital. So after a 9-day inpatient stay, the patient showed significant improvement. So since, as we know, in osteomyelitis case, it will require for around 4 to 6 weeks of antimicrobial therapy. So it's a long-term IV antibiotic therapy is being necessary. So he lives at home alone. In this scenario, what model of OPAT will be the best choice and why will we choose the choice? So we have 3 options to choose from. So the first one is the home-based OPAT model. Second one is the infusion center-based OPAT model. And third one is the skilled nursing facility-based. So the best choice in this scenario will be an infusion center-based model of OPAT or a skilled nursing facility or a rehabilitation facility. So why do we go for an infusion center-based model or a skilled nursing facility model? Why? So the one thing is the patient lives alone at home. So the patient should either self-administer or should appoint a nurse. So even if he appoints a nurse, the patient is 68 years, making it again difficult for the patient to do it as a self-administration. See, the SBA1C is 13. That means the patient is having uncontrolled diabetes mellitus. So when the patient is having uncontrolled diabetes mellitus, it's necessary that patient should be looking into the GRBS. There should be GRBS. Daily monitoring will be necessary. The second one is the creatinine of the patient, which is 1.3, which is a borderline creatinine. And a patient on vancomycin it's really important to have monitoring of creatinine. Since the patient is on vancomycin being a narrow therapeutic window drug and it needs to be monitored regularly, and TDM is also necessary in adjusting the doses of vancomycin. So taking into consideration all these scenarios, it is better if the patient is on an infusion center-based model or a skilled nursing facility so that the patient can have more access to getting the labs tested. So more than infusion center, a skilled nursing facility will be of more benefit in this setting. So types of OPAT care delivery. As I said, the first one is the home-based mode of OPAT. So medications are administered in the home, either by the patient or the patient's family member or by appointment of a nurse. So there is one more type of home-based OPAT model, that is a self-administered OPAT. We'll say it as SOPAT. So that is a home-based infusion without a home nursing. A physician's office will provide the training and supervision, either in a private practice or in a clinical setting. That is, there is no nurse to supervise. The patient is doing by himself. The next one is the OPAT at home. It's not the next one, so it's a continuation. OPAT at home incorporates insights by the home infusion nursing. So when a person is opting a home-based OPAT, it will be linked with home infusion nursing. So they'll provide the initial home training, and the nurses will be periodically visiting the house to make sure that there is proper adherence to the infusion therapies. So if the patient or the patient's family members are engaged in OPAT administration, they need to receive a formal training in IV infusion care from the physician's office. So whoever is administering the injections, they should have received a formal training. So now the nurses engaged in OPAT administration, whether even if it is a visiting nurse, it can be a visiting nurse. So this mode of a visiting nurse model is called as the hospital at home model. So this is a very common practice in Australia. Second one is the home health nurse. So home health nurse is appointed full-time at home for the patient care. So this is two types of care that the nursing can give to support the OPAT. So the next one is the infusion center-based model of OPAT. In infusion center-based OPAT, as we saw in the previous scenario, the OPAT care is delivered either in the physician's office or it will be in a designated infusion center. So this model works well for the patient who are physically capable of daily visiting. The patient should be physically capable of daily coming to the OPAT center and are willing to do that, and are not suitable for a home-based model. They will not be much suitable for that. So infusion center-based OPAT has been the dominant model in USA. So USA, this infusion center-based model is the most dominant. So the third one is a skilled nursing facility or rehabilitation facility. So the SNFs provide the greatest degree of medical oversight is given in the SNFs. So however, the care in SNFs, when you are going to a skilled nursing facility or if it is a rehabilitation center, there can be increased risk of exposure to nosocomial pathogens and there can be decreased patient satisfaction. So this is a table that shows differences between the hospital-based infusion centers and the home-based, and what are the advantages of each and what are the disadvantages. So hospital-based center infusion centers, definitely there will be expert resources available. It's directly supervised, and this can be combined with the physician's visit. So there is increased care there. And comparing it with the home-based, the biggest advantage is that there is decreased cost and there is increased patient satisfaction. Coming to the disadvantages of home-based infusion center is that the cost of clinical facility and the staff will be included there. And the patient must travel. The patient must travel from home to the facility. And there can be increased chances of nosocomial infections. So moving with home-based, the disadvantages, there is lack of on-site expertise is not there, and there is always a need for a home-based support should be needed. So next, after understanding the types of OPAT models, after selecting which type of OPAT model will be best for the patient, next we should think about the vascular access and infusion administration methods. So the first step in planning for any type of infusion therapy and placement of the vascular access device. So our goal is to use the least invasive VAD with the lowest risk of complication and one that will last for duration of therapy or will require minimum replacements. So the factors that guide to the decision-making process is characteristics of the prescribed infusate, what is the expected duration of treatment, the integrity of the patient's veins, the patient's mobility requirements, and the patient's preferences. So the vascular access and infusion administration methods are divided into two types. They are the central catheters and the non-central catheters. So looking into the central catheters, we'll be very familiar with the PICC lines, the long-term central catheters. In the long-term central catheters, we'll be having the tunnel central venous catheter and the ports. Ports may be new to us. It's more in the Western setting. So next we have the non-central catheters. In that we have the midline catheters and the short peripheral catheters. So we have the case scenario 2. So here there is a 30-year-old male patient with no significant medical history, and the patient is now presented with cellulitis of the left lower leg. The infection was caused by a Staphylococcus aureus, and it was confirmed through a wound culture. The patient initially received IV antibiotics in the hospital and has shown significant improvement. So the patient was treated with IV cefazolin 2 grams every 8 hourly. So he needs to complete a total of 10 days. So the patient already has received 7 days of therapy. And again, he only has 3 days of therapy to complete. So given the need for only 3 more it's not doses, 3 more days of IV cefazolin, which IV access device would be the best choice and why? So we have 3 options here. We can either go with the peripherally inserted central catheters or the midline catheters or the short peripheral catheters. So which IV access device would be the best choice and why? So for a short duration of outpatient parenteral antimicrobial therapy, the choice of IV access would be based on the ease of insertion, the patient comfort, and the minimal need for maintenance. So we should keep in mind all of this. And for a patient requiring just 3 more doses of IV cefazolin, we will only prefer a short peripheral catheter in most appropriate. That will be the most appropriate choice here. The peripheral IV catheter is easy to insert and remove, definitely, making it an ideal short duration therapy. It minimizes invasiveness of the short catheters, reduces risk of complications, and provides sufficient access for administering the remaining dose of antibiotics. So here we have an image of peripheral venous catheter. So looking into some quick points on peripheral intravenous catheters. So they are mainly used for short courses of OPAT, usually less than 7 days in patients who have adequate venous access. So there are some care and management PIV catheter include. So the patient must be educated on the following. That is ongoing assessment of complication of phlebitis or infiltration. So if any of this is there, there should be a prompt removal and replacement as needed. Stabilizing the catheter to reduce the risk of catheter movement within the vein and any accidental dislodgement. Maintaining an intact dressing over the site, and also to understand its importance of flushing with saline to maintain the patency after each drug administration or at least once daily. Protection of the site from water exposure. Also the prompt removal of the PIV when it is no longer necessary. So moving on with the central vascular access devices. So the most commonly used CVAD is the PICC lines. So selection of PICC lines is recommended for infusion therapies for more than 15 days. So now you can see a peripherally inserted PICC line. So now you have one that is tunneled. So moving on with the midline catheters. Midline catheter is a peripheral catheter. So this catheter is inserted to the upper arm, and the midline catheters are placed by specially trained OPAT members or the physicians. So these are the possible veins for the midline catheter placement. You can see the image. So we have case scenario 3, where a 45-year-old female, case of breast cancer with metastasis, known case of diabetes mellitus with a history of multiple hospitalization for infections. She developed a severe and persistent soft tissue infection secondary to her recent surgery. Now in palliative chemotherapy, she is in palliative chemotherapy, and due to her complicated medical history, a need for long-term antibiotic therapy is needed in this case. So the treatment plan is to start on IV ceftriaxone. She is scheduled for daily visits to the infusion center for her antibiotic therapy. So what will be the choice of vascular access device here? Keep in mind the patient might need a longer duration of IV therapies. We can use an implanted port. So this is not much seen in the Indian setting, but it is well accepted in the Western setting. So this is an image of typical implanted port system. So now we have a table where we compare between the peripheral lines, midlines, the PICCs, and the tunnel catheters or implanted ports. So the duration of therapy. So we should have in mind when we are planning an OPAT for a patient, what is the duration of therapy? Because the duration of therapy will definitely influence the vascular access device choice. And when after selecting according to the days of therapy, for example, if it takes from weeks to months, it's more preferred to use a PICC lines rather than using a peripheral lines. So after that, we should keep in mind what are the advantages and what are the disadvantages of each of this. As you can see, the peripheral lines, the advantages, it can be placed at the bedside without any radiological imaging. And the disadvantage being it is just for the short duration of use and not appropriate for vesicant medication administration. Whereas when it comes to the midline, it does not this also does not require a chest radiography prior to inserting a midline catheter, but it has a higher risk of thrombotic complications when compared to the PICC lines, and not appropriate for medications requiring central venous administration. Moving with the PICC lines, longer duration of use, you can definitely go for the PICC lines, maybe used for administration of vesicant medications also. So the placement of a PICC line will definitely require a radiological image or electrocardiogram technology for its proper placement, and may limit options for future dialysis access in patients with chronic kidney disease. So when you have the peripheral line for the PICC, then it becomes difficult for them to access the same lines for doing the dialysis process. So that is one major disadvantage of the PICC lines. So when it comes to the tunneled or the implanted ports, the duration of use is one of the biggest advantage, and it provides central venous access, lower complication rates when compared to the PICC lines, because in PICC lines you need to again go with the PICC line care. And also, the disadvantage is that the replacement or removal, the placement or the removal will definitely require a surgical procedure because it is tunneled or implanted ports. So we have another table that compares between the PIVs and the PMTs, the peripheral intravenous and the peripheral midline catheters. So one is for a short duration of 7 days, the other is for 2 to 4 weeks. Both of them are non-irritating, good for non-irritating, indicated for non-irritating infusates. And the advantages when we move across, that is the low risk of infection is there, lower cost is there, and it's placed by the nurses. Those are the advantages of PIVs. Compared with the midline catheters, there is low risk of infection, but improved dwell time compared to the PIV catheters because it's larger veins and less costly than CVAs. Disadvantages, the PIVs are for short term, limited in types of medications and solutions that may be infused, and the side may need to be replaced or rotated. And coming to the disadvantages of midline catheters, a trained person need to place this. It cannot be placed just by nurses. There should be a trained person to do that. And some patients might find it very difficult to use the midline catheters with the daily activities. It can be difficult, and signs of infiltration or phlebitis may be more difficult to identify because it is placed in the deeper veins, and there is risk of vein thrombosis. The next case scenario, we have a 46-year-old male patient with history of hypertension. The patient presents with chronic osteomyelitis of the right tibia. It is caused by Enterococcus faecalis. The infection has been confirmed through a bone biopsy and culture. Now, the patient initially received IV antibiotics in the hospital and has shown improvement. The plan includes an extensive duration of IV antibiotics. So, the patient is ideal for OPAT, and the patient is being treated with IV vancomycin. So dose based on the TDM for a total of 6 weeks. And the patient has already received 2 weeks of the therapy in the hospital, and the remaining 4 weeks is to be administered as OPAT setting. So given the need for 4 more weeks of IV vancomycin, which IV access device would be the best choice and why? So the PICC line is most appropriate choice. Long-term therapy minimizes the need for frequent needle sticks, and we can avoid a midline catheter because of the potential for local phlebitis can happen, or thrombosis and tissue clogging if extravasation occurs. And the same patient who was on IV vancomycin was sent for OPAT to home. So now after reaching home, during the home therapy with injection vancomycin, the patient develops itching and rash with flu-like symptoms. So injection vancomycin was administered over 30 minutes, and the patient represents with rashes. You can see the image. So what is this condition? So this condition is very common one. It's a red man syndrome. So what may be the reason for this? So injection vancomycin 1 gram IV was given as a 30-minute infusion. So ideally it should be administered slowly over 1 hour. So this is one of the disadvantages of OP settings. So we need to have a very proper understanding on each aspect of the injection, including the infusion rates, the frequencies, etc. So now comes the infusion administration method. So once you have selected the central venous catheter or the PICC line, whichever line you're going to choose for the patient according to the antibiotic. Next is the infusion administration methods. We need to be choosing whether it's going to be a gravity drip, IV push, a syringe pump, or an elastomeric balloon pump, which is also not much seen in the Indian settings, or the ambulatory electronic infusion devices. We need to choose from this what we are going to opt for our patient. So there are different factors to it. The drug, definitely, the frequency of administration, the drug stability in the solution form, the patient's safety and lifestyle concerns, and the patient's preferences, and definitely the cost. So here we can see images of some delivery systems. We have the syringe pumps, the ambulatory electronic infusion pumps. We have the elastomeric pumps, which allows mobility for the patient in the home care setting. So this is also accepted in the Western setting, where the elastomeric pump is regulating the stable infusions, and the medicines are loaded into the pump. So next we'll take a look into the IDSA recommendation. So IDSA recommendation was released for the OPAT recommendations was there of 2018. So we'll in between go through the IDSA recommendations for OPAT. So the first question is, in patients needing short course of OPAT, is it acceptable to use a midline catheter instead of a central venous catheters? So the answer is, in adult patients with short course, that is less than 14 days, a midline catheter may be used in compared to central catheters. Okay. So the second question is, should vesicant antimicrobials be administered via central catheters versus non-central catheters only? So that is a question. Whether if it is a vesicant antimicrobial, you should compare between the central catheters versus non-central catheters only. So there is no recommendation on that. There is no mandatory use of central catheters over the non-central catheters for OPAT. With vancomycin, it's not necessary, they say. Also, no recommendation can be made for the choice of vascular catheter for OPAT with the vesicant antimicrobial such as nafcillin or acyclovir. No recommendations and very low quality of evidence. Should patients with CKD requiring OPAT have a tunnel central venous catheter for vascular access rather than PICC? So for a CKD patient, the question is between a PICC line or a tunnel series. So then the answer is it is better to go with the TCVC is recommended, because as I said before, that is one of the disadvantages with PICC lines, because they need the peripheral lines for preserved for their dialysis procedures. So the next question is, should patients receiving frequent OPAT courses have a long-term central catheters inserted with the intention of leaving it in place? That is, should you leave a long-term central catheter in place between the antibiotic courses? There is no such recommendation made on that. Next it says, should the vascular access device be placed if patient develops symptomatic catheter-associated venous thromboembolism? So the patient is developing a venous thromboembolism while on OPAT therapy. So they're saying there is no necessary need to remove the vascular access device, and as long as the catheter remains well positioned and the arm pain and swelling is decreasing when you are giving an anticoagulant, and then there is no need to remove the line. But if the patient develops a fever or if there are signs of a systemic infection, the scenario is definitely different. Other than that, there is no need for removing the lines according to IDSA guidelines. So should patients with prior CABT be treated with prophylactic anticoagulation while on OPAT? So there is no recommendation on that, also has not been made. Next question is, should children receiving OPAT through PICC or LTCC? So for most children requiring OPAT, a PICC should be placed rather than a LTCC. Next, moving on with the clinical approach. What are the most common infections? Now we have an idea on what the vascular access device, and should we go with the drip system or elastomeric pump? We have an idea on that. Next one is, for this next we are moving on with the clinical approach. So what infections are the most commonly treated by OPAT? So one idea we have is longer duration of therapy. So what are those infections? Infective endocarditis or other cardiovascular infections, osteoarticular infections, abdominal infections, skin and soft tissue infections, or any other respiratory, genitourinary, or central nervous system related infections. You can go with OPAT. So the point to remember here is, whenever there is something that is equally effective bioavailability orally it's there, then we should opt for that than going for an IV parenteral therapy. Also based on microbiology, tolerability, or drug-drug interaction, oral bioavailability, and the impaired enteral absorption, you can decide on what antibiotic you need to choose. So there are some questions that we need to answer here. So before selecting a patient for OPAT therapy, there are certain questions. Is the patient clinical or ready for discharge to an OPAT setting? Is the patient's infection amenable to an outpatient treatment? Can the prescribed antibiotic be administered in the outpatient setting? If not, are there any alternatives? So is the patient or the caregiver physically and mentally able to manage the treatment protocol? Can the patient afford the cost of treatment if it is not covered by insurance? So in the vaccine setting, it's like if it's in the inpatient setting, and it's completely covered, and if it's in the outpatient setting, it's different in different places. So in India setting, mostly it's out of pocket payments are done. So we need to keep that in mind. Moving on with again some of the IDSA recommendation. The question is, should patient or the caregiver be allowed to self-administer the OPAT? So patient should be allowed to self-administer the OPAT if all the criteria are being checked. Should patient be allowed to self-administer OPAT home without a visiting nurse? So the patient may be allowed to self-administer OPAT at home without a nursing support, as long as there is a system in place for effective monitoring. So can a person who inject drug be treated with OPAT at home? There is no recommendation can be made with that. So should an elderly patient be allowed to be treated in OPAT at home? So elderly patient should be allowed to be treated with OPAT at home. This recommendation also assumes all the potential challenges with an elderly person such as mobility and other issues. So if you have a system in place to monitor, then they can be allowed. So should infants aged less than 1 month be treated with OPAT at home? There is no recommendation made on that according to IDSA. So is it safe and appropriate to administer the first opiate dose of a new antimicrobial at home? So if the patient with no prior history of allergy to antimicrobials in the same class, the first dose of the new parenteral antimicrobial therapy may be administered at home under the supervision of a healthcare professional. So keeping that in mind, if it is the first dose that the patient is going to receive, then it's better to have and supervision of the healthcare professional who are qualified and equipped to respond to any kind of anaphylactic reaction. If the patient is developing, then there should be someone to look after that. So you have the OPAT patient selection flowchart, which is very simple. Intravenous antimicrobials are included for management of the infection. If yes, then if there is an IV antibiotic involved, that being checked. Is the patient clinical situation, is it appropriate to send the patient for OPAT? If no, then patient should stay in the hospital. If yes, is there an infusion plan is simple enough for home administration or not? If no, if it is not that simple enough to be carried out at home, then we should send the patient to the infusion centers or rehabilitation. If it's the other case, it's simple enough to be taken up at home, then we should just have a check into the insurance and the cost, and then we can go for the OPAT. So again, now patient with infection warranting antimicrobial therapy, you have some questions here. Whenever you can change the patient to oral antimicrobial therapy, just switch it. If it is necessary to be maintained in IV therapy, then does the patient meet the OPAT criteria as like medical care does not require hospitalization, patient is stable to be discharged, and the patient environment is very safe and supportive. The patient or the caregiver is capable of safe and effective drug administration, and they are willing and they are able to participate, and there is access for them to therapeutic drug monitoring is feasible. So then initiate the patient with OPAT. So next we have the patient and caregiver skills. So there are 3 points. So this is important, that is to demonstrate, practice, and articulate. So the patient or the caregiver should have these skills, how to attach the antibiotic delivery device, IV catheters, and antibiotics on schedule. And the practice, how to conduct a sterile technique, which is very, very important. Sterile technique to reduce any chances of catheter-related thrombosis or infection. We need to prevent that and articulate the risk and the signs of any potential problems associated with home parenteral therapy. That include catheter-related infections or thrombosis or any adverse reaction that is coming up. They should be able to manage that. So antimicrobial selection for OPAT antimicrobial regimen should be clinically effective, safe, and relatively easy to administer and affordable. We should also keep in mind the efficacy, the toxicity, drug-drug interactions that can happen, the dosing schedule, and the drug stability at the room temperature, and what is the ease of administration, and the long-term, what can be the long-term toxicity and stability. So when there is, you understand that the scenario, there can be non-adherence being a concern, then you can go with a less frequent antibiotic dosing may be preferred. And you can always do modifications and include changes in frequency, route, and mode of administration according to the PK/PD of the drugs. So broader spectrum antibiotics require less frequent administration may be preferred in the home. Broader spectrum antibiotics that require less frequent administration may be preferred in the home setting. So it's very important when it's a home setting, you can always go with the less frequent administrations. So you have an example of a serious staphylococcal infection. It can be treated with intravenous penicillin G. So with penicillin G, which is administered continuously or up to 6 times per day, or we can go with the ceftriaxone. So which has a broader spectrum, but a lower cost, has a broader spectrum, but a lower cost and once daily dosing. So here, if it is in a home-based setting, it is better to choose ceftriaxone since it's an OD dosing when compared to the 6 times dosing of penicillin. You have a case scenario 6, case scenario 5, which is 56-year-old female patient. She was presented to the OPD. She had complaints of dysuria and chills. So urine routine showed numerous pus cells and urine culture was sent, and the patient was started on empiric antimicrobial therapy. So there was no signs of any kind of systemic infection. It was just a cystitis. And now the culture and sensitivity came and it showed an MDR organism. The organism is sensitive to meropenem and amicus. Which one should you choose? So what will you start for the patient? So injection amicus in 1 gram IV OD, 15 mg per kg for 7 days via a peripheral line. So why do we choose that? Because since it's a systemic, since it's not a systemic infection and it's just a cystitis, and taking into consideration is for shorter duration of 7 days, and the amikacin can be given as OD and it's fine as peripheral line, you can go with amikacin. So now we have the list of antimicrobials used for outpatient parenteral antimicrobial therapy. You can see very commonly used antibiotics in Western setting and yeah, even in the Indian setting, some of them are used. Like you can see ertapenem, piptas, yeah. So 4 strategies to simplify antimicrobial therapy in OPAT. So consolidation with broad spectrum, it's not actually to use a broad spectrum antibiotic in OPAT, but as we discussed in the before scenario, when you have a penicillin, which should be given as 6 times daily, 6 hourly, from that in comparing it with an OD dosing, it's always, if you have such an option, you can go with it. And whenever there is a once daily is there, then you can go with the once daily. And you can always employ programmable pumps for continuous or intermittent infusions for Q4 to Q6 hourly drugs. And also, whenever there is a possible IV to per oral switch, then that is if a drug is having very good or excellent bioavailability, you can always switch. So one of the drugs that we always switch in our setting is the linezolid. So it has 100% bioavailability in as orally. So there is no need for giving it as IV. You can, whenever the patient can already orally tolerate it, you can give it as the tablet. So now when the choice of the drug is also made, then we need to consider the safety monitoring. So in safety monitoring, we should be aware of what all drugs possesses what all toxicity. So I have just given a few here. Vancomycin nephrotoxicity, aminoglycosides, electrolyte imbalances caused by certain drugs, the hepatitis, cytopenias, metabolic disorders caused by daptomycin, and therapeutic drug monitoring is necessary in case of vancomycin and amikacins, aminoglycosides, etc. So what are the practical considerations? The doses should be easy to initiate and administer. And there should be minimal manipulation of these IV lines. It should be easy to operate the infusion devices. And while selecting the antimicrobials, you should consider the solubility, the stability, and whenever possible, the PK/PD considerations. And frequency of laboratory monitoring. When you should do a laboratory monitoring, you should be aware of that. You should counsel the patient on that. Antimicrobials with infrequent dosing and prolonged stability are more encouraged, with very few serious side effects. So, and no need for laboratory monitoring is kind of the ideal features. So the frequency of administration may also influence the drug selection. When feasible, less frequent administration schedules is more convenient. The resulting less frequent line manipulation. So when it's less frequent administration means less frequent manipulation of the lines, and reduce catheter-associated complications like hematomas, catheter migration, central line-associated infections, bloodstream infections like serious infections like CLABSI, and catheter-associated thrombosis. So drug stability, the antimicrobials should be whichever antibiotic you are recommending should be stable in the storage conditions up to 1 week after mixing. So therefore, a short-lived stability of some beta-lactam antibiotics makes it actually difficult for home-based OPAT settings. So like if an IV push delivery over 1 to 2 minutes can be utilized for an antimicrobial, in particular if you say cephalosporins, they can be given, they can be supplied as ready-to-use syringes for IV or IM administration. That is the better choice. That is more more easy for the patient to use. So drugs suitable for once daily dosing usually have prolonged half-life, and the PD properties allows infrequent dosing. So we have an example of daptomycin here. So next is the time-dependent antimicrobials with short half-life necessitating numerous daily dosing, which is not that easy. So then nafcillin, such drugs such as nafcillin may be suitable for continuous or intermittent automated infusions if stable. So again, it's the same. It's a safe approach to OPAT. So we need to evaluate the response of the patient to the treatment. So also we should identify and prompt identification and management of any drug allergies or adverse events should be there. And therapeutic drug monitoring should be ensured to avoid any toxicity happening. And care should be given, proper care for the vascular access device. Dressing changes should be made. And frequent consideration of continued need of therapy that we need to check on that. If it is not necessary, please stop that and switch to the oral therapy. And ongoing evaluation for any drug interactions can happen. The management of side effects and evaluation of secondary infections like antibiotics can give way to Clostridium difficult colitis. So the patient should be educated on these aspects. In safe approach, there can be weekly laboratory monitoring is recommended for the patient. So if we are saying that CBC should be measured, even if the patient is receiving parenteral antibiotic that has very little or potentially no cytopenias, even if it doesn't have any potential for cytopenias, since it is not just the drugs area that we are looking into. Since if when we look into the CBC, if it is a WBC or eosinophils, there may be important markers or clues for a secondary infection that can happen. For example, a catheter-related infection may be going on, or maybe allergic drug reaction. So the patients who are not seen weekly, we should think of additional monitoring structures that need to be in place so that we don't miss anything out. So here are some recommendations for weekly laboratory monitoring, such as if it is with the meropenem, you need to have a weekly laboratory monitoring for CBC, LFT, and RFT can be done. And for vancomycin, definitely you need to do an RFT at least weekly and CBC combined with it. And areas you should be careful about the nephrotoxicity or infusion related reactions, the red band syndrome. And moving on with the trimethoprim sulfamethoxazole. So weekly monitoring of CBC, LFT, RFT can be done. There are additional things like hyperkalemia, rash, nephrotoxicity, Stevens-Johnson syndrome. And linezolid, definitely thrombocytopenia being the ADR. And you can look into the CBC, LFT. So you need to have a broader idea of what are the monitoring parameters after deciding on the antibiotic therapy. When the patient should notify you on the labs and when all it should be checked. So what does the IDSA say? Should patient receive OPAT have laboratory testing monitoring while on therapy? If so, which test should be done often? So serial laboratory testing should be monitored. That is what the IDSA is saying, and there is no specific recommendation or regarding the specific tests and frequencies. They have not commented anything on that. For patients receiving vancomycin as a part of OPAT, should vancomycin serum levels be measured regularly throughout the course of treatment? Vancomycin blood levels should be measured regularly throughout the course of OPAT treatment. That's what they say. So they're saying the optimal frequency of measurements, it's actually undefined, but general practice in the setting of a stable renal function is once weekly. Next is how frequently should an patient on OPAT have scheduled physician office visits? How frequently should they go and visit the physician? There is no general recommendation made on that. It is based on individual patient scenario. So what are the major challenges? So the most commonly encountered in the practical setting is the ADRs and complications associated with the vascular access devices, and also adverse drug effects, fever, diarrhea, or rash, or may have laboratory abnormalities in the absence of symptoms. So patients with fever or any significant diarrhea or loose stools more than 3 times per day or rash should be instructed to seek a prompt clinical evaluation. So clinical measures of OPAT. How can you measure if your OPAT plan for the patient was successful or not? So the clinical status, you can look whether there is improvement or clinical failure or there is no change. The program outcome, therapy completed as planned or therapy not completed, then you can look into the reasons. Complications such as vascular access complications, adverse events, or allergic responses to antimicrobial agents, development of thrombus, catheter-related bloodstream infections. You can look into the complications. And how was the healthcare utilization? You can look into that. So now you have a 45-year-old male patient, history of mitral valve prolapse, hypertension. Patient is presented with 2 weeks fever, history of fever, night sweat, fatigue, and new onset heart murmurs. So febrile systolic murmurs at the mitral area, elevated white blood cells, CSR, CRP, etc. And the blood cultures, there is Streptococcus viridans, and the echocardiogram shows vegetations on the mitral. So what is the confirmed diagnosis is gram-positive bacterial endocarditis due to Streptococcus viridans. So initial inpatient management was for Streptococcus viridans, infective endocarditis of the mitral valve. The patient was initiated on IV penicillin G, 3 million units every 4 hourly, and gentamicin 1 mg per kg every 8 hourly for the synergy. So the response was the patient responded well. The fever was resolved within 48 hours and the inflammatory markers started decreasing and hemodynamically the patient is stable. So now we know when the patient is hemodynamically stable, that's the apt point for transition to the OPAT. So the rationale is stable condition. So now the patient is in stable condition, need for prolonged antimicrobial therapy, and the patient preference for home treatment. So after considering all of this, the OPAT plan was antibiotic regimen of IV ceftriaxone 2 grams once daily, selected for the ease of administration and the coverage. And maybe you can also look into the MICs. And you can go with the selecting of the ceftriaxone. And the monitoring plan was, so this case scenario discusses everything what you need to look into when you are planning a patient for OPAT. So monitoring plan is weekly blood test for complete CBC, renal function, and inflammatory markers. Patient education should be provided, and any signs of complications, when to seek medical help. Recommendation IV line will be a PIC line because it's longer duration of therapy of 4 to 6 weeks since it's an infective endocarditis. And monitoring and follow-up, you need to make strategies and schedules for that. So you can plan, like there can be a home visit by the nurse or bi-weekly consultation. It can be telehealth check-ins. Also, you need to schedule on the lab draws and when to do the next echoes and when should be the follow-up, at least a monthly follow-up in the primary with the primary care provider should be initiated. You can also check with the outcomes, that is, was there a complete resolution of the infection? Was there normalized inflammatory markers? And there was no recurrence of symptoms. And the quality of the life of the patient can also be evaluated. So now moving towards the end, the future directions and in India and the research needed. Although there are many challenges in OPAT, after going through the slides, we'll understand that there are a lot of benefits also for the OPAT. And so in India, there are certain challenges. Definitely the infrastructure and the resource constraints. There are limited healthcare facilities that with necessary infrastructure to support the OPAT setup. So, and also there are lack of trained healthcare professionals, nurses, and pharmacists to administer or monitor care in the OPAT setting. This is definitely a huge opportunity for the pharmacists to, in OPAT setting, there is a lot of things that they can focus on and come up with. Okay, the next challenge is the cost and the reimbursement issues. So in India, it will definitely be an out-of-pocket expense for the patient. So the biggest problem is if the patient is having a coverage or insurance coverage, only if the patient, most of the insurance coverages, only if the patient is inpatient, they'll get. So the patient might say, I'll stay inpatient rather than I want the comforts of the home. So that's a challenge. There is lack of awareness and acceptance. And there is no regulatory or policy is not there. So that's next challenge. challenge, and there is lack of proper system of monitoring and follow-up is not there. Also, there can be antimicrobial resistance. So rising antimicrobial resistance, making a challenge to select the effective antimicrobial for opiate. So then there is also a huge opportunity for the antimicrobial stewardship program to look after the opiate. So the IDSA say should all patients have ID expert review prior to initiation of OPAT? All patients should have an ID expert review prior to initiation of an OPAT. So this is a great opportunity for the stewardship. So this was, even though there are very less articles from India, this was one of the articles. So in this, they have actually compared with the efficacy and the cost of ertapenem in outpatient setting for extended spectrum beta like VSBL causing enterobacteriation in acute pyelonephritis condition. So what they could see is it was administered as opiate in 90% patients, and it significantly reduced the overall treatment cost. So there are studies like. So here you have another study that was published in the Antibiotics Journal in the year of 2022. So that looks into the current practices and opportunities of outpatient parenteral antimicrobial therapy in hospitals. So this is a good article to read more about OPAT. And here you have one in therapeutic advances in infectious diseases. This was published in the year, I think, 2023. So this is looking into the best practices, implementation, and what are the challenges of OPAT. So this was a result of the worldwide survey among healthcare providers. So I thought it would be interesting if we have a look into the facts that they have seen in OPAT. So this study is more like giving us some future directions of how developed in other countries the OPAT system is. So they're saying that it is definitely amazing to have a multidisciplinary team as advisory board. Anyway, there should be an ID specialist and ID specialist to monitor the system. If there is no multidisciplinary team, it could be an ID specialist that is being responsible for the advice. So in contrast, there were settings from which a specialized nurse team was also mentioned several times as the best practice. So they are just looking into some best practices worldwide. So it was not just a multidisciplinary team. It was not just the ID specialist led OPAT, but in contrast, there was some nurse team that did some best practices. And moving on, another common best practice mentioned was the use of elastomeric pumps. That is also very accepted in the Western setting. We have seen the images. And they're concluding as if there is good cooperation and communication between the stakeholders and there are proper protocols, then you can do an OPAT system successfully. Good cooperation and communication between stakeholders is very necessary. And in some settings, they've seen giving laminated sheets with instructions to educate the patients who are self-administering OPT has been identified as one of the best practices. And even another hospital was developing an app for patients to allow better communication in the OPT settings. So what are the key takeaways of OPT? So ensure appropriate patient selection should be. Making sure that this candidate is the best suited for OPT. Utilizing the correct IV access device based on the therapy duration. We should emphasize a multidisciplinary team approach. We should address all the stakeholders. Provide a comprehensive patient education and support is very important. Optimize cost and resource utilization, and follow-up definitely should be there. Focus on the positive outcomes and the quality of life improvements that OPAT can make in the life of the patients. So these are some major references I've quoted here. I've definitely gone through the IDSA. You can all go through the IDSA guidelines, and also the IDSA have a handbook of outpatient parenteral antimicrobial therapy. The third edition, there is also the UK upgraded good practice recommendation for outpatient parenteral antimicrobial therapy. If you are wishing to start an OPAT in your setting, what are things you can look through? That was published in the JAC journal. So Thank you.
Thank you, Dr. Swati. That was an elaborate and, comprehensive presentation for this outpatient service. I admit that we have a very lack of awareness and infrastructure for conducting this kind of practices in India. However, it will be accepted soon because of its high benefits in terms of
Yes,
cost.
yes.
So let me ask you, what all the factors has to be considered while opting this particular therapy for patients with altered renal function?
With altered renal function, definitely a home-based therapy will definitely be difficult in a patient with altered renal function. Because if it is an antibiotic that is supposed to have a renal clearance, then the creatinine clearance based dose adjustments will be necessary. Then the patient should be opted for a infusion center based or a skilled nursing facility based mode of OPAT setting. And also further saying, if the patient is having a renal impairment, we should also think about whether we should choose what kind of IV access line. So as we are saying that if it is a peripheral PIC line, then it will be difficult, because if the patient is going towards dialysis, then for the dialysis we need to reserve these peripheral lines. So we need to keep all of this in consideration, and according to patient basis, we can definitely decide on whether to choose the patient for OPAT or not.
Okay, Dr. Swati, thank you once again. Thank you for your wonderful session. And to all the viewers out there, thank you so much for patiently hearing us. Thank you.
Okay, thank you, Vinaya. Thank you.